but I'm assuming, Christmas is around the bend, so maybe people are traveling or something like that. So we're going to get started. Um, I think we're just going to jump into it. So, I'm sorry, am I pronouncing your name right? Desalu?
Exactly. The
Oh,
Salo.
okay, so you're on. So if you could share your screen and present your case, then we'll get started.
Okay, all right. Okay, how are you all? Let my greeting reach to you from a
We can see.
distance. Pardon? I have a case of 70 years old girl. I am the Salo from Ethiopia. In short, this girl is presented with vaginal discharge of menstruation, and her menarche is 12 years. On physical examination, they noticed that there is foul-smelling gray-white vaginal discharge. On rectal digital examination, the 4 by 5 centimeter solid mass felt on the anterior wall. PVOs differed because she has no history of any sexual contact. MRI was carried out, and I would read the result. There's extensive circumferential vaginal wall and uterine cervical polypoid mass involving the whole vaginal wall with retained vaginal secretions. Post-contrast study showed irregular enhancement of the vaginal and cervical intramural mass lesion. There's no pertinent finding in the other regional related organs. With this, the radiologist's impression was embryonal tumor and rhabdomyosarcoma. This is the biopsy report. This is poor handwriting, but it shows that there is incisional biopsy was sent to our department. In terms of finding, they noted that there's fungating fair mass over the upper pseudovaginal wall with polypoid projecting mass from the cervix. Upon accession of the tissue in our department, we received in bits, in fragments. The maximum diameter is 2 centimeters. They are gray-white and gray-brown. So small tissue was received. As to the microscopy, sorry, this slide is not good. It shows that it's clearly depicted here that the lining epithelium is squamous epithelium, and the stroma is, it shows diffuse infiltration. Actually, it's low power of small lymphocyte-like cells at this magnification. This another tissue showing mucus-producing columnar cells, probably endocervical tissue. More closer view, it is clearly seen that the surface epithelium is squamous. Some cells may look like coelocytes, but I'm not sure. The squamous epithelium looks bland, but there's no clear demarcation from the stroma. It blends with a cellular proliferation of cells with clearly visible hyperchromasia and discohesiveness. There's no, at this magnification, clear evidence of epithelial invasion, infiltration, or the tumor may not, it doesn't seem to arise from the overlying epithelium. Just deep to the tissue, the tumorous tissue, it shows that the cells are numerous. It is hypercellular. Strikingly, there is clearing of cytoplasm. Some cells have well-defined cytoplasm. This is clear. This cohesiveness, it is featured. It may present, they present in a trabecular or cord-like pattern. They are discohesive. And clearly we can see that the cells, the nuclear pleomorphic, hyperchromatic, and they are from round to spindly in morphology. A better, closer view shows that the cells are highly pleomorphic. Yeah, there are some spindly, others smaller. So there's a wide gap between wide gap of size. There is size variation. Hyperchromasia is marked, and this clear space. I'm not sure if it is cytoplasm or not. Some nuclear indentage pushed aside by this content. This one, and if you continue, some part of the tissue shows a spindling of the nuclei, the sarcoma-like feature. This cohesiveness is still retained, and these clear spaces are still accompanying. And these cells, they show the mitotic activity is brisk. Here in the you can see the mitosis, nuclear irregular, hyperchromatic, prominent nucleoli in some of the cells. Okay, more closer view. And the last slide, mitosis is clearly seen here. It is frequent, and the cells are highly pleomorphic, hyperchromatic, with prominent nucleoli, and some cells are indented by this clear space, like signet ring. So with this, we signed out as undifferentiated high-grade malignancy. So we have listed differentials as the index case is a girl, young. Our top differential is rhabdomyosarcoma, and undifferentiated carcinomas. Pecoma, usually rare, but because it is a regional tumor. And non-Hodgkin lymphoma is questioned. With this, we ordered markers. By the way, our institution lacks immunohistochemistry service. We are running out of that, and these patients are subjected to pay with an affordable price in privates. That's why we have limited this immunomarkers to 3. Otherwise, we had to order panels. Surprisingly, oral negative. Pancytokeratin is negative, and the contrast is positive. Myogenin, it is negative, and the contrast is positive. HMB45, still negative, and the control is positive. Desmin, negative, and the control is positive. All markers are negative. Save that there might be technical problems for the negativity, or it may be truly negative. Our second consideration is we cannot rule a clear cell variant of non-Hodgkin lymphoma, diffuse large B-cell or peripheral T-cell lymphoma. So the remaining work is to do further immunomarkers like markers for B-cell and T-cell lymphoma, for B cells and T cells. So we found that this case is very difficult for us. We discussed among ourselves, ancillary techniques. The last resort should be the ancillary techniques. So I've shared this document to Professor Olowole. I'm sorry if I have not spelled. And I think further the next discussion will be among us. This is, we try to this extent. Okay, thank you for hearing me. That's all.
I'm sorry. So Olu, did you see the case? Do you want to comment on it, or do you have a different case?
Yes. I saw the case, though I have to say that I kind of thought of it as a vaginal mass, but it looks like it is it's something that involves both, circumferentially involves both the cervix and the vagina. And I'd raised the possibility of yolk sac tumor. You know, even though keratin is said to be negative in this particular case, and usually vaginal yolk sac tumors are seen in younger patients. But with that possibility, in the setting of a cervical mass, then of course we have to consider, you know, sarcomas that are not, that haven't been specified here, like an erectodermal tumor or something like that. That's maybe it's DICER1 related. And that's something else to consider. And of course, all of that assumes that you know, there are no technical factors, and that lymphoma has been excluded. But I, you know, thought the case was challenging, you know, and so I'll be glad to see what everyone else thinks as well.
Lewis, do you want to go ahead, or Ekene? Any thoughts?
Yeah, I think sorry, I think I have an echo. Yeah, I think it's definitely a challenging case. I guess I kind of agree with that thought of, you know, kind of yolk sac. That was the only thing I was kind of considering as well. I think that's a good avenue to pursue. But yeah, I think, or other types of sarcomas. I guess, did she have anything? Was there the imaging in the ovary? Was nothing in the ovaries? Is that right? On the imaging?
No. There's no any reading from the ovary. She's there's no reading. The pertinent finding was found only on the cervix and vagina. Yeah.
Okay.
Challenging case.
So my thought, I mean, obviously all of the differential diagnoses that you all mentioned, I will throw in one more, which is myeloid sarcoma. Although truthfully, I don't see the features, but you know, I would have done stains for that. My biggest concern is that this is some sort of a dicer related tumor. So I guess we lovingly call them diceromas till we settle on a new, you know, on a real name. So I've seen one of these things which we actually published just last year, and you know, the age of the patient, I think, raises that concern for me. They tend to have this small cell appearance and one that doesn't fit into any category. So, you know, without additional stains, I don't know what other differential I have to throw in there.
Yeah, I think the DICER1 business, actually, we also had a case where it mixed embryonal rhabdomyosarcoma with something neuroectodermal tumor, and it was centered in the cervix in a 20-something-year-old. And after the therapy, the neoadjuvant therapy, it kind of got rid of the embryonal part, but the neuroectodermal part was sitting there, and the morphology of the neuroectodermal part was not like classical, and it was all edematous and stuff. So I always raise that possibility for this, you know, unspecified sarcomas in the young, centered in the cervix, that, you know, this could be something DICER related.
So she doesn't, there's no previous history of anything in the thyroid or lungs as a child?
Actually, there is no any clinical data or profile regarding the other systems. Just upon presentation, simply they have evaluated the genitourinary system. What we have found on their on her record is only the gynecologic area.
I see. Because Dicer patients often in childhood have, you know, pleuropulmonary blastoma. They can have thyroid abnormalities, which present earlier. So I was just wondering if that might help us point us to a diagnosis. How big was the mass?
On physical examination, on digital rectal examination, they have estimated 4 by 5 centimeter. On operation, they have not measured. Simply, they have noted that it has involved the upper two-thirds, so the vaginal wall, with circumferential manner, and there's projecting polypoid mass from the cervix. Exact dimension of the mass wasn't recorded on the operation note. At most 5 centimeter.
Interesting. After I will send out an article that I'm sorry, I remember these by author names. So I think Glenn McCluggett had an article a couple of years ago, and incidentally, I'm reminded of it because the age is exactly the same as your patient's. The patient was also 19-year-old, and I think it was a single case report, and it was a weird sort of rhabdomyosarcoma was amongst the differential diagnosis of, obviously in that case, the diagnosis was established by molecular studies, and it was a Dicer-related tumor, and it sort of was vaguely reminiscent of rhabdomyosarcoma also. I'm sort of inclined also to say that I feel that there might be a fixation or other issue with the tumor because all of the stains have been completely negative, right? We don't have any positive stain, not Vimentin. Yeah, so I feel that to some extent we are being, you know, I think that the stains are spuriously negative. What do you use for fixation in your lab?
Yeah, formalin.
Neutral
Buffer formalin.
Yeah, and is there a delay to fixation by any chance? Like how soon from the OR do you get the sample?
Actually, it's difficult. We simply proceed to process immediately. After we receive the tissues, unless it's grossly large tissue, which should be bisected and have to take time for fixation. Just as small biopsies, and immediately they are going to be processed soon.
So I guess my question was OR to lab time because, you know, during my residency, and I'm quite old, you know, our lab wouldn't bring, we would not process specimens over the weekend. So typically Thursday and Friday specimens were often held over till Monday. And so the quality of material on Monday wasn't good. So it didn't have to do with what was happening when the specimen was received in pathology, but prior to that. So I'm just throwing that out as potentially a reason for why the immunohistochemical stains didn't work. So I'm sorry that we don't have a definitive diagnosis on this case. We would do more immunostains and possibly also molecular stains, but it does seem to fall in the generic sort of sarcoma family. Louis, any last thoughts on this case?
Yeah, so we had the same sort of an issue that came up in a case earlier this morning on the Kenya tumor board. with the young girl with the cervical mass and so forth. And consideration was, is it rhabdomyosarcoma, or possibly is it one of these lesions that has a Dicer mutation? And we didn't discuss it at the time, but I wonder, if we were to establish that sort of mutation, whether or not, or what sort of follow-up these Dicer patients need to get. And because oftentimes I think we as pathologists are going to be the ones to suspect or detect that possibility and potentially make the recommendation for ongoing follow-up to establish or rule out these additional lesion that develop in ovary and lung and so forth. So anybody have thoughts or experience with what sort of a follow-up regimen is recommended?
Yeah, so I can actually post the recommendations if people want it. So a couple of years ago, there was a proposal for Dicer syndrome surveillance. I don't remember the specifics, but I do remember the parts that I remember is that they need to get pulmonary surveillance, pulmonary, renal, and thyroid, and their specific recommendations for each, and also for the ovaries. The interesting thing that I also remember is that these were actually all time limited, like up to 40. So I think for the lungs, this stops at 10 years because the PPBs always present in the pediatric age group. I think the renal also stops before 10 years of age. And then thyroid and ovary actually sort of start when the pulmonary and the renal surveillance stop and go on till, I don't know, 40, 50 years of age. So I will post those after the meeting so that people can look at it. But again, I'm not sure whether that sort of surveillance is possible in low resource settings, because a lot of it has to do with sort of CT scans at some, regular intervals. But it seems to me that that's the category that this case is most likely to fall into.
So one other comment just on the staining, Dr. DeSaldo, your controls looked very good. And that's an important consideration. I know in a number of developing situations where they don't get good controls, or the controls don't work very well. But Dr. Vanita's comment about fixation, the controls are only good if they really match the other processes in your laboratory. So if they were processed differently, they're fixed well, but your tissue patient sample isn't, then the control really doesn't do its job. And so that's a very important consideration, to kind of make sure that the controls that you select are processed in a fairly comparable way to the way that your laboratory specimens are processed, so that you really get a true picture of whether or not your stain is working.
All right, then. So Olu, it's all yours. And you're going to have to talk at double speed so that you can fit it all in the remaining time.
Okay. All right. It says I can't share. You cannot start screen share it.
It's because
So that's all you need to.
Yeah.
Yeah.
Can I stop sharing?
Yes.
Yes.
Thank you.
Okay.
All right. Let's do this. There's something on my screen that refuses to go away. Okay, now I got that. Pardon me, but I sort myself out a little bit. Okay, let's see. Okay, I think I should get it now. All right. Do you see that?
Yep.
All right, so let's go to there. You're looking at the proper view, right? Yeah.
Yeah.
Okay. Okay, so the Clinical history here is 59-year-old that presented with vulva itching, goes back at least 6 weeks, that had been unresponsive to some fungal creams and then a topical steroid. There have been no discharges. So on physical examination, it had been shown to be slightly raised red patch around 11 millimeters centered at the right labia minora. So a biopsy was obtained. And this is just the sort of general low power appearance of the little fan. We'll take them piece by piece. And so the first thing you notice, there's a dense sort of dermal, almost lichenoid kind of infiltrate. There are also areas of non-specific kind of sclerosis, most clearly discernible adjacent to the basal layers. There are also other areas elsewhere where the nature of the dermal change is best described as fibrosis, if you will. And then regarding the epidermis itself, all of it seems abnormal to various extents. It's a mixture of inflammatory and some nuclear alterations whose precise nature is not immediately apparent. So, you know, in this area of the sample, you can see there seems to be some interface activity a little bit there at the base. The nucleus maybe a little bit larger and darker, but it certainly is within the spectrum for something that's entirely non-neoplastic. Other areas, you have more disorganization, including some enlarged nuclei. Let's go and look at higher magnification. You can see that there's some nuclei that seem larger and darker, and if you go even further with in that area, you start to appreciate mitotic figures. There's the one there, and there's a cluster here, and again, there's a certain disorganization of the spinous layer overall in this whole region. Here you can see it looks like a lot of the action is more towards the base, but again, the whole point of this one is to show, the image on the right is to show that it does extend upwards. Now, regarding this area that invaginates inwards, we were not able to clear this. It's not, we even re-embedded it, but we were not able to clear it. It does invaginate in that where there's some kind of an annexal structure here. That's the reason for the invagination. And you go on higher magnification, you're able to appreciate that the epidermis or the spinous layer, if you will, that lines this whole area is basaloid, and there's a lot of mitotic activity and some atypia as well. Higher magnification, start to appreciate lots and lots of mitotic figures, and some of these cells that, again, is tangentially cut, yes, but still, a lot of significant atypia and some pleomorphism, if you will, shown here and here as well. And so that's kind of the way it goes throughout this lesion. At the very tip here, something pops up that looks, you go on higher magnification, you see that there's a certain lack of maturation. Now it's probably because some of it has been cut up the top of it, but this is what it looks like. And that area seems to show a higher proliferative index in this particular tip. And just something else to mention in this overall piece. This whole lesion is P16 negative. And we did it again. We did in situ hybridization as well. And it was negative for HPV high risks. We did P53, and it had a kind of a weird staining pattern. All of it seems to be null, except only a small segment of the epidermis shows the normal staining pattern, if you will. So either everything else is abnormal or there was something else wrong. I'm sorry that it looks a little blurred, but there's staining in the sort of internal control. It seemed okay. this is that segment area that looks, normal in terms of wild type staining at the base of the epidermis. But in any event, this whole portion in the middle was entirely null looking, as was most of the epidermis. So if you have to summarize sort of the pathological features, then we say, okay, there's some epidermal atypia, at least 2/3 of the way up. Certainly seems to be some increased mitotic activity, at least half up. It's P16 negative. It shows mutational staining pattern for P53. It was negative for fungal forms. I didn't show that image, but it was negative. And there seems to be no evidence of invasive cancer. You could argue that some of that sclerosis is indicative of sort of lichen sclerosis in terms of pathologic findings, if you will. So our differential diagnosis included just a high-grade squamous intraepithelial lesion because of all that, atypia in the spinous layer, mitotic activity. One must also consider differentiated vein, as well as non-neoplastic kind of reactive changes. So the sporadic multinucleated cells that one can occasionally see in the epidermis, or pseudoboenoid changes from polyfill treatment or the like. But in all of those changes, you generally don't see mitotic figures of this level of atypia. And the multinucleated cells are generally not diffuse and just occasional in an otherwise bland background. So I think realistically, the first two are the most likely differential considerations. Of course, we know that squamous intraepithelial lesion that's HPV associated can be very inflamed and reactive looking, and some of this is an example that's shown here with a lot of inflammation. Here's another one that shows florid spongiosis, and you have to kind of look carefully to appreciate that this is indeed an HPV associated intraepithelial lesion. But in either of those scenarios, one can demonstrate that there's some evidence of, HPV association. It's P16 positive, it's in situ, HPV in situ positive, or whatever else one does to do that demonstration. But our case was negative. We ultimately settled on a diagnosis of differentiated vulvar intraepithelial lesion because we do have, we interpreted that as P53 abnormal staining pattern. It's non-HPV associated, and it's dysplastic looking. Now, I'll go into DVAN in some detail. DVAN was originally described several decades ago, and the basic features of DVAN, as reported in that original paper, for the most part remains true today. That is, that the in situ phase appears to be of short duration, and it's frequently seen at the margins of resections. Now, over the years, the terminology has kind of evolved and started out with the hypoplastic dystrophy with atypia, and ultimately VIN of the differentiated type, to where we are today, which is DVAN as a subset of HPV independent VIN. And that's kind of where we are today. DVANs are generally a disease of individuals who are older than 50, although there's increasing diagnosis in young age because there are two peaks for lichen sclerosis, and one of them is in the very young. And so untreated, you start to get DVAN in the 30s. But for the most part, DVANs are generally seen in individuals who are older than 50, actually older than 60 average. Most of the DVANs are centrally located. Or at least they start out in a central location, hairless skin, mucocutaneous junction, non-keratinized squamous epithelium. The appearances vary, could range from something that's sort of glazed, plaque-like, any number of potential appearances of this sort. And they can range from anywhere from 5 millimeters to 35 millimeters in this classical series. Most examples of DVAN are diagnosed concurrent with an invasive cancer. And when they're seen in isolation, they can be quite difficult to diagnose. Indeed, when a patient who has lichen sclerosis is subsequently diagnosed with an invasive cancer, when you go back and look at those lichen sclerosis biopsies, a lot of them turn out to be DVIN. In one study, about 42% of them had DVIN within them. Again, so as a practical matter, that just means to be paying a lot of attention to diagnosis of lichen sclerosis in general, and really always making sure that these cannot plausibly be DVIN. What is the natural history of DVIN? Well, so there are a few studies that have looked at the issue. You can see the percentage with follow-up cancer ranges from 32.8, and to this something of an outlier study from the Vancouver group, where they found almost 86% of patients had follow-up cancer. But what I think all of them agreed on is the time to progression was relatively short. The median time to progression was less than 2 years for all of them, in all their studies. Indeed, if you look at sort of registry data, and you look at the 10-year cumulative risk for developing squamous cell cancer. So here, the lower line is regular HPV-associated HSIL. And you can see, at 10 years, the cumulative risk is around 10%. But for DVIN, at 10 years, the cumulative risk is about 50%. And you can see the nature of the curve, how it's, the risk is just much, much, much higher for DVIN as compared to HSIL. So of course, this is a distinction that should be made. The treatments are also different because, yes, most of them are treated by surgery, at least in the United States, but there are non-surgical treatments for HSIL, whereas there are none for DVIN. As I mentioned before, the diagnosis of DVIN continues to be problematic. Here's a more recent study where 4 pathologists, those that specialize in GYN, skin, general, they looked at a bunch of cases, and this is not really about how you add the individual features to get to a diagnosis of DVIN. It's just, are these features present at all? And you could not get a lot of agreement on some of these things that constitutes the hallmark for the diagnosis of DVIN. For basal atypia, the kappa value was around 0.56. And basal atypia is important. An earlier study from the Duke group from 2016 had looked at, had asked 23 gynecologic pathologists who focus in this area. And only basal atypia met consensus as being essential for the diagnosis of DVIN. So the basal atypia in the epidemiology really is very important for the diagnosis of DVIN, if we can agree on what constitutes basal atypia. Recently, well, no longer recent, 2 years ago, the International Society for the Study of Vaginal Diseases, their difficult pathologic diagnosis committee, came up with some criteria for the diagnosis of DVIN. And you can see here amongst the features, basal atypia is the key one, is the only one, that everyone agreed needs to be present. Of course, it needs to be P16 negative. There's some controversy on whether or not you can be P53 wild type or aberrant. ISSVD believes that you can be either. But they also, what's nice about this paper is that they outline the supportive features. And in the sort of terminology for DVIN, a lot of the way they use terms doesn't quite match how we use the same terms in dermatopathology. So one kind of needs to kind of look at it with some caution. But in any event, the supportive features fall under what they call dyskeratosis. And, most of these supportive features are seen in keratinizing types. So you have intercellular degeneration and breakdown and what looks like spongiosis. And then you have premature maturation, which can be in the form of just a spinous layer that looks prematurely pink, or loss of a granular layer. So these are just the supportive features, but while we're here, I hope you can appreciate that there's basal atypia here. But separate from that, in terms of supportive features, are this intercellular degeneration that looks kind of like spongiosis. I'm not sure you can actually tell them apart. The vacuoles and stuff that are within them. And then you have premature maturation where everything turns pink immediately after the basal layer, as shown here. But ultimately, what matters is the basal atypia. In that paper, they published a couple of things that they define as basal atypia, or they call basal atypia, and provided a definition for them. And in this sort of system, you need two of these features to get to basal atypia. And, you know, this is just a description of them. So you can be hyperchromatic, dense chromatin, but you can be vesicular as well. Nuclear enlargement, at least 3 times the size of a lymphocyte, to be kind of diffuse, mostly separate from the background of venous atypia. Then pleomorphism, something marked variation in cell-to-cell sort of shape. And mitotic figures, which is probably the most dangerous one, essentially greater than 1 mitotic figure per 1 millimeter of basal cell layer. And if you have any 2 of these, that gets you to basal atypia, which most likely gets you to a diagnosis of DVAN. That according to ISSVD. Now, here's some examples of fairly clear-cut cases of DVAN. We have basal atypia. I've put green arrows at the tip of this thing, and they meet criteria because they show hyperchromasia as well as nuclear enlargement. So we have at least 2 features, but they're also supportive features. In this case, premature maturation, everything looks abnormally pink, and it gets pink immediately after the basal zone. And then there's also loss of the granular layer in this particular example. This one, you can see that there's some atypia. It's a little bit more subtle, but certainly it's there, right, at the tip. And then supportive features, premature maturation, loss of a granular layer. This one does have a granular layer, but there's still atypia, and it just goes to show that outside of basal atypia, very little can be depended upon in terms of sensitivity and specificity. And so this one does have basal atypia, it does have a granular layer, but I appreciate the intercellular separation. It looks like spongiosis and vacuoles as well. There's a background of lichen sclerosis here as well that's useful. And this is more of a traditional DVAN with elongated rete, irregular rete. You can again appreciate some lichen sclerosis here, some intercellular degeneration, atypia, basal atypia. Okay, shown here. This is P53 that's shown on the lower left. Here's one where the atypia is more subtle, you know, but I still think it gets you to a diagnosis. Look at the tip of the arrow. Appreciate nuclear enlargement, has enlargement and hyperchromasia. So those 2 features get us to basal atypia in and of themselves. On the other hand, some cases are very subtle. And for example, I would argue that this is not diagnosable as DVAN, not to my eye anyway, but we identified it as DVAN in the context of a study, or at the very minimum, it's P53 abnormal, which is shown on the right, but it's very, very, very subtle, and that's something else to keep in mind. Some people have referred to this as subtle DVAN. There are other morphologic patterns of DVAN that should be borne in mind. So here's something that's atrophic. This is the non-keratinizing intermediate form. I'll show another example of that. Remember, the non-keratinizing forms are intermediate and basaloid. And most of the intermediate forms are non-keratinizing. I'll show an example that's still keratinizing. And then you can have the hypertrophic. All these examples I've been showing are generally hypertrophic. And then a camptolytic variant. And the important thing is just to keep in mind these possibilities, because it's not immediately intuitive that that could be DVAN if one is not familiar with them. So, you know, Again, acantholytic with all the splits, and it looks like a medical disease of some kind until you do p53. And then, atrophic as well. So again, here's a keratinizing intermediate. You look at it, it's a clinically discrete lesion. So it's biopsied and then excised. And you can see between the blue lines is the sort of lesion. And what you do at higher, it actually had been done in the prior biopsy, shown to be p53 positive. But, what you immediately notice is that there seems to be a poor maturation in this particular zone, and hence the term intermediate. It's not quite basaloid, but it's not quite pink either. It's sort of intermediate in appearance, hence that name. But there's still some basal atypia, right? There's some basal atypia that gets you to the diagnosis. But it's important to remember the intermediate variant of DVIN, and that can be quite subtle as well. Now, some examples of regular HPV-associated H-cell can have atypia that's restricted to the basal third, if you will, and then you have to look, you start to appreciate mitotic figures midway through. Some other areas may have atypia. So this is the so-called DVIN-like pattern of H-cell. And if you did p53 and p16, you'll be able to immediately prove it. But it's just important at the morphologic level to know about the DVIN-like pattern of H-cell. But this is our case. There's also another sort of variant of DVIN that's H-cell-like. So just like there's a DVIN-like pattern of H-cell, there's an H-cell-like pattern of DVIN, and some of our case shows some basaloid features. And so we talked about the non-keratinizing types, and one of them is basaloid. We talked about the intermediate already. The basaloid variant of DVIN was initially described by Dr. Odi in 2009. By definition, the basaloid variant of DVIN is histologically indistinguishable from H-cell and at the morphologic level. They then did another study in which they looked at almost 800 HPV-negative squamous cell carcinomas and found that, a lot of, a subset that had adjacent skin. They looked at almost 800 that had at least 1 centimeter of adjacent skin, and about 1/3 of them had some kind of premalignant lesion, and about 10% of those showed basaloid or warty morphology. So here's a case from adjacent to an invasive cancer. It looks like it should be H-cell, but if you did p53, you find that it is not, and p16 here was negative. There's some evidence that when you have that basaloid DVIN adjacent to your vulvar squamous cell cancer, that those patients do worse. This is from a recent study showing that HPV-independent vulvar squamous cell cancer that's H-cell-like, those lesions, those cancers that have that lesion with them, they do the worst as opposed to regular cancers, HPV-independent cancers with DVIN, or those that are HPV-associated, which of course do the best. Regarding immunohistochemistry, just a word in terms of what to do in this setting. Well, I mentioned before that there's some controversy as to whether or not whether you're allowed to be p53 wild type in a DVIN, and I think that's still unresolved. But I think most series, at least contemporary series, have found the vast majority of DVINs, cases that are classified as DVINs, to be p53 abnormal. Of course, there's a circularity there because they usually don't select the cases unless they're p53 abnormal, but it is what it is. In terms of interpretation, there are some well-established sort of interpretation pattern of p53 now. So the mutation patterns are either staining the base and extending upwards, or null or cytoplasmic. And then there's the basal pattern where there's strong staining of the base, this pattern is associated, can be associated with a mutation, but they're non-specific because they can also be associated with inflammatory diseases. For the wild type patterns, either they're scattered or you have mid epithelial staining and no staining of the base. That's considered a wild type staining pattern overall. And you generally see that in H-cell or HPV associated things. Of course, in real life, it's never quite that simple. There's some obvious P53 abnormal here. There's some wild type here, but you often get this sort of problematic scenarios like it's staining only the base, but they only in a discrete area without a morphologic correlate. But sometimes it extends up a little bit slightly. It looks stronger than it should be. And we know this is a non-specific pattern. And sometimes, again, you get the discrete areas where you have to wonder, is this staining strongly enough? So there could be some problematic scenarios, but luckily they are uncommon. A variety of markers have been proffered as being potentially useful for the diagnosis of DVIN. I would say none of them are really ready for prime time overall. The one that we've studied recently is GATA3. There seems to be some partial loss of GATA3 within DVIN cases, but you also see loss within VAM and a variety of other lesions. So it's unclear exactly, whether there are any markers. And GATA3 has its own problems, Sometimes it's just reduced expression throughout, or it's retained in cases that look like DVIN at the morphologic level. Subsets of VAM and VIN3 also show loss of expression. So overall, I will still try to depend as much as I can on that morphology to get to the diagnosis. DVIN also affects margins, very key, important thing. And so I showed you image before where we started discovering this sort of DVINs. This is not something that we originally did. Other authors have done that. So here's a margin status, which these authors found did not really influence risk of local recurrence. We've generally used that 8 millimeter cutoff, 8 millimeter, 8 millimeter, 8 millimeter, but these authors found that it doesn't affect recurrence. What does affect recurrence is DVIN at the margin, or DVIN and lichen sclerosus at the margin, but mostly just DVIN at the margin. And so I think that's the main role of the pathologist, is to make sure that we recognize the field, to make sure there are no DVINs around our excisions. As we all know, these excisions are getting smaller and smaller and smaller. And so it's sort of important to try to recognize the margins and to make sure, because if you really map out your margins, you find that a lot of them are P53 abnormal. And it's not just an academic exercise, because it's been shown that the P53 abnormality at a margin is associated with a 3-fold increased risk of recurrence. So, even if it's morphologically occult and P53 abnormal, however you want to call that, it's associated with a 3-fold increase in recurrence, according to the Vancouver group. Some other people also believe that lichen sclerosus at the margin matters. I think it's just trying to sort out what is lichen sclerosus versus DVIN versus morphologically occult DVIN and the like. I think that's really the main thing, because we know all of these things frequently coexist: DVIN, lichen sclerosus, and invasive cancer. So I'll end by saying DVIN is a precursor to HPV-independent squamous cell cancer, and potentially has a short duration between its diagnosis and evolution to cancer. It's typically diagnosed adjacent to an invasive cancer in resections. The diagnosis continues to be problematic because, again, it can be quite subtle. I think there's a general consensus now that basal atypia is a requirement, but some cases are very subtle. As I mentioned before, it's controversial whether P53 wild type is acceptable. I think, again, as pathologists, one of the key things to do is to make sure that we recognize DVIN at the margins of resections for vulvar cancer, because that can affect recurrence. And I think that's it. Can take questions.
Great.
All right.
Questions, anyone? Okay, I'm actually going to jump into a couple of announcements and take up a couple more minutes of your time. So next session, I am going to make an executive decision and say there will not be a case presentation. We're going to discuss the potential for 2 class projects that will hopefully result in publication. In fact, this is hot off the press. So Dr. Fadari, you're part of one of these projects. So I had submitted a proposal to the International Society of GYN Pathology to pull together a group to think about chronic endometritis. So that has been approved, but one of their comments was that, you know, we need to focus on diversity. So we're going to focus on that. I'm going to reach out to them and see if, you know, this group can involve as a class with the hopes that we can come up with recommendations that are sensitive to low resource settings also. The second class project is something that some of the ICGS folks have been interested in, which is synoptic integrated reporting for various gynecological cancers. And I think Dr. Okekwe and some of their gynecologists have been involved. So I will just lay out the structure for the project, and hopefully everybody's interested and will involve in it. And then we should be able to get out a paper that is coming from low resource pathologists on what type of synoptic integrated reporting works for them. So just to let you know, there's an ongoing project with CAP that they're doing, and there's also an ongoing project with the WHO, but both projects do not have significant involvement of pathologists from low resource settings. And I think it's very important that people who practice in that setting actually develop the plan for how or what will work for them. So I'm going to lay out the plan for that, and then you guys can think about it, and you can say, no, we don't want to do any of this stuff, or yes, we do want to do some of this stuff. And I think that's what we're going to focus on next time. And but if somebody has a case that pops up, just shoot me an email and we'll make 15 minutes for case presentation also. All right. Okay, guys, thank you very much. So you'll get emails from me, and we'll see you in a month. So I think that's January 17th, same time. All right,
Thank
guys.
you.
Thanks, everyone. Happy
Bye.
holidays.
Happy
Bye.
holidays,
Thank
everyone.
you.
Yeah.
Thank
Bye.
you.
Bye. Thank you.
Bye. Thank you.